My name is Vinod Patel. I'm a consultant oral surgeon working at Guy's Hospital and also the service lead for dental services for cancer at Guy's as well. I have a specialist interest in management of oncology patients with regards to their oral and dental care before and after their treatments, and particularly interested in osteonecrosis of the jaw, either via radiotherapy or via medication. And essentially, I want to talk to you about some potential treatment options that have advanced in osteoradionecrosis via the use of medical management. Jaw necrosis or osteonecrosis of the jaw is essentially when bone, wherever it may be in the body, dies and loses its vitality, so its life, its inability to function normally or repair itself, for instance. We see lots of it in association with the jaws because of two main issues, either radiotherapy or medication. And essentially, when it's related to radiotherapy, it's given the name osteoradionecrosis, or commonly you hear clinicians use the term ORN as the acronym. Essentially, the condition, when it occurs, causes quite significant trouble, such as pain, swelling, or infection. And the most common appearance of it is that you see exposure of the jawbone where naturally you shouldn't. So the gum peels away, and you get evidence of the jaw coming through, which may be white in color, yellow in color, or it could eventually over time become a brown or black color. So the management of osteoradionecrosis is on a spectrum at the moment in terms of how it's managed, and there is no real accepted treatment of how it should best be managed, which is agreed across the international community, and that's been the sort of approach over the last few decades, essentially. Naturally, we fall towards surgery because they're often looked after by the surgeons, and we feel we can sort this out via surgery. So naturally, that goes hand in hand. But traditionally, the treatment was antibiotics, and it still remains one of the approaches. The initial attempt at using antibiotics was to cure it, but now we tend to use it as a stabilization approach more than cure. Some patients are cured of their osteoradionecrosis via antibiotics, but it's never the absolute intention to do that because we don't feel like it's purely just infection related. Apart from antibiotics, the main approach is, as I said, surgery, and that could vary into two different sort of camps. The first camp is sort of debridement surgery, and what that essentially means is trimming away or smoothing or polishing away areas of necrotic or dead bone so that you can try and seal the gum over the top of it. That can only really potentially be offered if the necrosis is limited to a small area that you feel that you can define by looking at appropriate scans or x-rays. Essentially, when it's quite extensive, then you fall into the other camp, which is resective surgery. So they remove a segment of your jaw, and it may or may not then be replaced by bone from elsewhere. It could be from your leg, from your arm, from the back of your shoulder, or even from your hip, but not necessarily always from those areas, and not necessarily always requiring reconstruction or replacement. Those surgeries can sometimes be supplemented by something called hyperbaric oxygen therapy. And hyperbaric oxygen therapy has been around for about 30 years or so, popularized by an American trial. And the aim here was to try and boost the blood supply around the bone, because that's why we think the bone has died. The blood supply and the oxygen levels around there are not good enough to keep the bone alive. So hyperbaric oxygen is used to try and boost as best as possible the blood supply and the oxygen around it so that the surgery will work better. It's sort of slowly fallen out of favour here in the UK for various reasons. Most recently because of the Hop-On trial, which showed that hyperbaric oxygen didn't provide the advantages that we thought it would. And then the last option is something called medical management, so using drugs or tablets to try and boost the blood supply and the oxygen levels around the area, essentially to get the jaw to do a lot of the work. We often call it triple therapy, and these medicines are pentoxyphylline, tocopherol, or vitamin E as it's more commonly known as, and sodium clodronate. And together these medicines work to jointly improve the blood supply, repair the damaged bone as best as possible, and eject away some of the bad and radiotherapy necrotic bone out of the jaw, so that the body can retain what is they feel is relatively healthy. So they're the three main treatment options that are available at the moment, to varying degrees across the world. So the triple therapy, or Pentaclo, which is the acronym we use for pentoxyphylline, tocopherol, and clodronate, Pentaclo, has had mixed reviews from everyone in the wider community that looks after osteoid necrosis, commonly because it hasn't been proven to the long-term extent as some of the other options have been going for. And so there's always some skepticism when something new is introduced, because we don't know the long-term outcomes and whether the results are truly the way that they've been reported, or whether they are potentially biased. And so I can understand there's some skepticism around it, but there has been some studies done, particularly from the French group, who were the first to introduce it, and it's been available for at least over 10 years, openly for the treatment of osteoid necrosis, with some very, very impressive results. Here in the UK, it's been used for about 10 years, and there's only a handful of people initially using it, but there has been a slow increase in the uptake of this option, and lots of people managing osteoid necrosis are slowly increasing their use of it, because they're starting to see the advantages of it, particularly because they see the potential failures of surgery and their concerns about offering such radical surgery and the outcomes that come with it. I think over time, people will consider its use more often, but the big thing that they want is a big randomized clinical drug trial that will take a long time for us to be able to provide that, but it will come over time. Our results that we're producing at the moment are relatively good. There is no such thing as 100% success in any treatment option that's been available for osteoid necrosis. And so in comparison, we found our results here to be comparable to those of the French group, which is around about an average of 55 to 60% healing rates when given in osteoid necrosis. Now, that depends on the varying severity of the osteoid necrosis, and with any disease, the more severe it is, the more difficult it is to manage and the longer it takes. And so there are some nuances to the treatment and how long it takes for various people, and associated risk factors that come with it. But I think the concern here is that people try to use it and they are not patient with it, and therefore they feel, oh, it doesn't work, and then they either suggest that it's an inappropriate treatment or one that cannot solve the situation. But we have to recognize that the treatment of using medical management is not quick or fast, and so it requires careful evaluation of the patient, regular review of the patient, and then compliance, most importantly, from the patient to take the medicines that are prescribed.